that these red areas that you can see here, these represent very low availability of C-sections. You can see most of the state is red, and some districts are showing us, for example, Champaran 5.41%, Saupal, Bihar 3.69%. The benchmark is 15%, medically necessary. This is total C-section rate, which suggests that a lot of it could be elective, and that medically necessary C-sections are not being made available to people. And this is across the entire state. And this is 2019-20 data. This is not old data and does not include the situation that we saw during COVID. Similarly, if I go back and ask the question for the state of Uttar Pradesh, for example, again, you will see the situation being quite comparable. You can see the splash of red everywhere, particularly in the northeastern parts, of Uttar Pradesh. You can see numbers are really very low. Bahraich at 5.2%, Shravasti at 3.23%. And these are large districts, 2 million, 3 million people each in these districts. So really what's happening is that secondary care, and this is total C-section rates, not just the government. So which means neither the private sector nor the government are able to step up to provide this care. The numbers, in fact, I have them here. There are 20 districts in Bihar that have less than 10%, 9 districts in Jharkhand, 17 in Madhya Pradesh, and 25 districts in MP. Just to have a sense of what a district is, on average, it's about 2 million people is one district in India. So when we say 25 districts don't have C-sections above 10%, that means 50 million people are being denied access to this. Research also indicates one of the responses that the government has come up with is insurance schemes and to make available what is going on. Research is showing us that merely adding insurance does not result in increased supply of secondary care, even from the private sector. You see a response in dental care, in eye care, supply response, but you don't see it in the creation of secondary care hospitals in these areas. This suggests to me that if the availability has to improve, the government will need to focus on actually making their secondary care facilities operational, completely free and high quality in all parts of the state. If for the moment we forget about tertiary care and we say, okay, that's a separate problem for another discussion, this summary analysis suggests to me that while these low-income states should indeed focus on improving the quality of the primary care already on offer, their investments should focus on essential public health services and on secondary care. We already know that essential public health services are vital. But the question in front of us is this true of secondary care? Particularly given our narrow focus on maternal and child health. Shouldn't we just focus on primary care and not worry about building any emergency care capability or any other way in which people get access to more advanced care? To discuss these questions, I'm going to turn to the expert panelists to share their view with us. Each of them has examined this issue quite carefully, some from data perspectives, some from other environments, and some from direct hands-on action. I'm going to first turn to Dr. Lee to talk to us. She's a senior health systems researcher at Yonsei University in South Korea and Harvard University in the US. She's part of a group of South Korean researchers who have taken a keen interest in Indian health systems and have published a series of deeply insightful papers in the last 2 years. The one I found particularly fascinating is a 2022 paper in Nature, in which Dr. Lee is the lead author and examines the impact the increases in institutional delivery rates have had on maternal and child health outcomes in India. We know that the government has tried very hard through multiple programs to persuade women to deliver at what we would call an institution. The question that her paper examines and has some startling revelations is what has been the impact of this going forward. Dr. Lee, may I invite you to share your views with us? Thank you.
Thank you for wonderful introduction of me. I'm gonna share the my slide. Sorry. Okay. So hi everyone. First of all, I'd like to appreciate the opportunity to speak with Lancet Citizens Commission on the topic of how to use the limited resources on areas of maximum impact. What I'd like to emphasize in my talk today is that to maximize the health impact, we need to care about not only access to the essential health service, but also the quality of health service. To achieve the universal health coverage, policymakers have to determine how to allocate limited resources for health efficiently. So usually, essential package of health service has been regarded as a useful mechanism to prioritize limited resources for health. Essential package of health service is defined as a set of health service and product that can be feasibly financed and provided for everyone in each country. And as I know, India has an essential package of health service that specified clinical or public health service, and it's in use, but it depends on state and district. Also, the coverage of health insurance and essential package of health service is not aligned currently. When we talk about the essential package of health service, one thing we definitely have to have in mind is the quality of service. No matter how many people can use basic service, if the quality of service they use is poor, it cannot lead to a good health outcome. These are the graphs taken from Lancet Global Health paper. And all bars here are countries that have achieved the institutional delivery between 80 and 90%, which is quite high. But the maternal and neonatal mortality vary widely, even though we categorize the countries into similar economic status. This means that the quality of delivery service the formal health facility provides is very different, and it affects the outcome beyond the access. And this graph were also taken from the paper based on Indian National Family Health Survey that I worked with Professor Subramanian and also Dr. Niket introduced in the first. In this paper, we scored the quality of antenatal and postnatal care the pregnant woman received at the formal health facility, and then calculated the average score at district level, and then divided them into quintile. And so the first quintile is the district with the poorest quality of health service, and blue dot and red dot here indicate the predicted neonatal mortality born at home and at institution respectively. And we found that in district where the health service quality is the poorest, the predicted neonatal mortality was higher among institutional birth than home birth, although the difference is small. And as the quality of service gets higher, the benefit of institutional birth compared to home birth in terms of reducing neonatal mortality got bigger. The pattern was similar when you looked at early neonatal mortality. Then, what is the health service quality? We can refer to the high quality health system framework. So this is by Professor Crook team at Harvard in the paper of Lancet Global Health, where the most integral part of high quality health service is process of care, which is process of care, which is composed of two subcomponents. Competent care means evidence-based care, which is related to clinical care, such as correct diagnosis, treatment, and counseling, and so on. And user experience means, for example, whether the people were treated with respect or non-discrimination, or whether the patient had to wait long to see doctors, and so on. And these are the most important aspect of the high-quality health system. Then, how can you improve the quality of this process of care? The answer is the foundation here can control the health service quality. Sometimes a tool component has been mistakenly used as a quality indicator, but it's not itself a measure of quality care, but it's just the foundation to produce a process of care. For the foundation part, I'm just gonna very briefly mention due to limited time. First, population can determine the quality of health service as the agent who can hold the government to account. So government need to give people platform to express their health needs and include people's voice during all process of policy. As for the governance, political commitment is very important, and to ensure the long-term political commitment, policy people should be able to provide robust data showing the poor quality of care linked to the higher mortality, as I showed in previous slide. And then also, quality care package is not necessarily expensive, and it's affordable. Platform means a venue where service is delivered, and provision of right service and the right platform is very critical to maximize the use of resources. Currently, there are many mismatches in the platform in low and middle income countries. For example, many countries adopt two-tier model in delivery service, where only high-risk mothers delivers at the hospital and low-risk mothers deliver at primary care facility. However, risk prediction model is intrinsically not accurate. So even in high-income countries, about 30% of low-risk mothers develop emergency obstetric events during the labor. In addition, chronic disease management, which can be easily handled in primary care, are currently being provided at higher level facility. This is creating geographic and financial barrier to the service. And finally, reform of medical education to improve the quality of health professional and some input to facilitate the procurement of medicine and establish a health information system might require a bit of budget, but also can improve the health service. Yeah, this is what I prepared for today's presentation.
Thank you, Dr. Lee, for sharing with us these insights that quality matters. And I found your graph that shows the split as the quality of care improves between home births and facility births to be quite fascinating. One question to you, Dr. Lee, in your analysis of Indian data, do you have a sense of, if I look at districts or whatever unit you looked at, how many fall in the first quintile and how many fall in the last quintile? Do you have a sense of, is this like a small group that's in the first quintile and most of our districts are in the fifth quintile already?
We just divided by the by 20%. The lowest 20% is the first lowest. Yeah, not by the absolute criteria.
So if we take, say, about 800 districts, then what you're saying is that each one is about 1/5 of that total number that we're talking about, 160 districts in each quintile. Would that be correct?
Yeah, right.
Wow. So what you're saying is that it's possible, though the numbers may vary precisely a little bit back and forth, that somewhere near 300 to 400 million people are receiving very low quality care, even though
right.
they are delivering at institutions, but they're not getting the care that they need.
Yeah, right. So, like if the institution quality of the health service the institution provide is poor, the outcome might be worse than home birth.
Wow,
Yeah.
that's a startling finding. You mentioned that it's not expensive necessarily to get good quality. Could you talk a little bit about that as to what you meant by that?
Yeah, here we constructed the composite score of health service, which is composed of 11 individual components of care. For example, mothers being whether the mother was weighed at antenatal care visit, or the mothers got the blood pressure taken at antenatal care visit. This kind of the service care component is not that expensive to be provided. So even if it's the very basic service, if the provider strictly follow the guideline, they change the health outcome. So it's not necessarily expensive. Yeah, although some of the service is expensive, like as I mentioned, some reform of medical education to basically improve the health professional, or some input to improve the procurement system of medicine. That kind of intervention might be expensive, but not necessarily all are expensive.
Thank you, Dr. Lee. That is really quite a remarkable set of findings, and gives us a lot of food for thought. I hope we come back to it in our broader discussion as to what we might do. May I turn to you, Dr. Nimako, for your comments now. Dr. Nimako is a Ghanaian physician and researcher currently joining us from Accra, with a keen interest and expertise in systems for maternal and newborn health service delivery in developing countries. In his work, he has been thinking deeply about the design of developing country health systems. I was particularly fascinated by his insightful December 2021 paper in The Lancet, which was titled "Seizing the Moment to Rethink Health Systems." We, Dr. Nimako, are very much here to seize the moment. And he has on-ground exploration of some of these ideas that he's been talking about in Kenya that he can share with us to see where the opportunities are and where the challenges are. Kenya is not India. There are many differences between our states, but I believe there are important lessons that we can learn for us as we think about our own health systems going forward. May I invite Dr. Nimako to share his views. Nimako, you're on mute.
Thank you. Thank you, Dr. Moore. It's a great pleasure to be part of this panel today. Nice to hear my colleague, Dr. Lee, who I was with at Harvard, speak. And I'm going to be building on a lot of the points that she's already raised. And I'll be focusing on how we can think about outcomes and the need to evolve health systems to meet continuously the needs of the population. So I know we don't have much time, so let me delve right in. And I'll be focusing on maternal and newborn health. There's a graph that some of you may have seen, and I like it so much because it gives us the view of meeting the 2030 SDG targets. What you can see is that many countries, most countries in sub-Saharan Africa and South and Southeast Asia are off track to achieving the SDG targets for mothers and newborns and children. And India is no exception. India is off track to achieving the targets for child health. So there's a lot of work for all of us to do. And in thinking about the progress we've made over the years, we have made some progress. One of the key indicators we've been using is facility delivery rates. And Dr. Lee just talked about how facility delivery rates do not equate to improved outcomes. It's the same slide you are seeing on the left here. The independence of economic level, just because you deliver in a facility doesn't mean you have a positive outcome. And this is juxtaposed with the graphic you see on the right, which is showing that about 60% apologies for that. My internet just dropped. I hope you can hear me just fine now. Can you hear me, please?
Yes,
Okay,
yes, Dr.
We can hear you.
Excellent. Someone will say these are high-income countries. Well, in countries like Peru, Argentina, Brazil, upper middle-income countries, not very different from India, is the same scenario. And when you compare that to the outcomes that they have there, they have much, much lower mortality. So there's something to say about delivery in a hospital versus a primary care facility. And this is not just an ecological fallacy. There's evidence to show that independent of the volume of deliveries, hospitals provide higher quality of care for mothers in the intrapartum period than primary care facilities. And this is by design. Dr. Moore talked about this earlier. Primary care facilities are not designed to manage complications, severe complications that will lead to poor outcomes. So we know this as a global health community, and we've tried many things over the years. One is to improve the process of care at the primary care facility. Another is to do risk stratification, and another is to do referrals. And I know that Dr. Lee has spoken about this already. The sum of this, the summation of all of this is these are reaching the limits of their impact. Today, the residual mortality we are seeing demands more. And so we need a rethink of how we are delivering maternal and newborn services, especially in the intrapartum period. So this is the basis that forms the recommendation for service delivery redesign. And this is a recommendation to maximize outcomes and not just access. And for maternal and newborn health, service delivery redesign is a proposal for all births to occur in a hospital or within 30 minutes of facility that can provide definitive care for complications. This is capacity for cesarean sections, blood transfusion, care for the sick newborn. Along with this, the primary care will need to be strengthened to provide care that is at the core of its competency. Dr. Moore just mentioned that only about 10% of mothers are receiving the full complement of antenatal care. There's a component of care that needs to be improved there. Antenatal care, postnatal care, ongoing newborn care needs to be delivered well at the primary care level. And this should be the focus there. And then overall, we need to ensure that there's high quality access and financial protection for the population. So this is the concept of service delivery design in brief. And if we're able to do this well, the benefits are, as you can imagine, number one is the mortality benefits. Because mothers and newborns have rapid access to life-saving care, we are able to reduce mortality. And the other very important benefit is that we're able to concentrate efforts in fewer facilities so that we don't spread our resources too thin and we are more efficient with the resources we use and we are able to maximize outcomes as we are improving access. Let me use the last few minutes I have to speak briefly about Kakamega County in Kenya, which is implementing service delivery redesign. It's in the process of implementing service delivery design. They have numbers that are just like many other places. Maternal mortality and newborn mortality are high. And the difference here than compared to many other places is the recognition of the need to do a rethink. So I'll use this slide to show how that conversation has evolved. In 2019, the government recognized the need to, in Kakamega County is one of 47 counties, and working together with Harvard and with the Gates Foundation and many other partners, they conducted a feasibility assessment to understand the capacity of their health system to deliver high quality care for mothers and newborns. Through that, they designed a model of care around service delivery design, where all deliveries will happen in designated hospitals with primary care facilities managing antenatal and postnatal care. They are currently in a system improvement phase where they are where they are increasing human resources to ensure that they are up to standard. Please pardon me. It seems I got a little too excited there, so this cough that is I'm recovering from has just gotten exacerbated. But back to the Kakamega story. The county is currently in a phase of improvement where they are ensuring that roads are improved, human resource capacity is increased, and transportation is in place to allow for this transition. And once all of that is in place, they will have the policy rollouts where mothers will now be asked to deliver in these delivery hubs. So this is an exciting journey that's happening in Kakamega currently. And let me end with these lessons that we've learned so far. The first is that visionary leadership is essential for any kind of health system reform. Because this is not just changes on the margins, it really requires a vision for improvements that has benefits down the line, not just today. And that is what we see in Kakamega County. The second is that you need, the second is that service delivery design is a very gradual process. It has to be done meticulously and deliberately to limit the risks. But the third one, which I think is the most important, is that it is possible. Once there's visionary leadership and there's a will to improve outcomes, we can really make a difference and improve the outcomes for mothers and newborns. So let me stop here and hand over back to Dr. Moore while I pause and cough some more.
Well, thank you, Dr. Nimako, for a wonderful presentation and sharing with us this experience on the ground of this. I had a few questions for you, but maybe I will come back to these questions later once your throat has settled a little bit. Are you able to answer any questions right now?
Yes, absolutely.
So one of the debates, Dr. Nimako, at least in India, and I wonder if you encountered this in your work in Africa and in Kenya, is that really we should focus on primary care. If we are improving maternal child health, we should focus on primary care. And that government should really invest all its resources in primary care. There is very little support, both amongst large donors as well as amongst the government, to really focus on hospitals, which is why you see, I mean, I showed you the graphs for 1920. What I didn't show you was that in many of these districts, these rates have fallen from 15-16. So they were low in 15-16. They're even lower now. What is the government doing? it's building more primary care, and not how do people react to your suggestions in an African context, and how do you respond to that?
Thank you, Dr. Mo. I think this is a very real problem. Developing partners, governments see primary healthcare as the do-all, the be-it-all, as the direction of travel for universal health coverage. And they are not wrong that PHC is critical for achieving UHC, but it's not the end, because PHC can only do so much. Now, the preventive promotive component of healthcare is critical to limiting the need for clinical services, in-facility services. But if you look at the need for the capacity and the competence in providing antenatal and postnatal care, it leaves so much to be desired. So that is where the focus of primary healthcare should be, ensuring that the primary healthcare is able to deliver services that is at the core of its competence. And if you're talking about maternal newborn health, I see that to be antenatal care, postnatal care, so that they don't miss during antenatal care multiple pregnancy, which has an impact on delivery. Once that is done, there's so much need for improving the capacity of the secondary facilities, the primary hospitals, to deliver the emergency care that the primary care cannot deliver. And that, just because you're expanding primary healthcare doesn't mean that all of the services that the health system should provide should be done at the primary healthcare level. And that's what a lot of countries are now realizing. And so working in Kakamega, it is quite gratifying for the government to see the need to ensure that the secondary level is also being improved to be able to handle these critical components of service delivery, like emergency care, and in this case, for maternal newborn health, intrapartum care. So it is a challenge to really contextualize the need for improved secondary care along with primary health care. And like you say, a lot of donors are also looking at primary health care as the future, and that is also detracting away from the secondary care. So there's a lot to do to redirect this conversation, and thanks for bringing that up.
Thank you, Dr. Nimako, for that insight. I hope we will have time for a discussion in which we will come back and talk about this a little bit more. May I now turn to Dr. Evita Fernandez. We've heard Dr. Fernandez from global experts on what is going on both in their own countries, as well as an analysis from the outside, looking at data, looking at analytics, of what is happening in India. To introduce Dr. Fernandez, she's not a new face and a new name for us here in India, particularly in the health systems world. She's the chair of the Fernandez Foundation, which runs the Fernandez Hospital in Hyderabad, amongst many other things. She's an obstetrician and a fellow of the Royal College of Obstetricians and Gynecologists. Her hospital is based in a state which is known for excessive use of C-sections. So I'm sure whenever she hears the word hospital, she's thinking, and I thought there'd be real value in, Dr. Nimako, could you stop your screen share? I wanted to share a screen. I'm not able to do so while you're doing it. Yeah, thank you. I wanted to show you the situation that we are facing in her home state. So this, what you saw, is Uttar Pradesh. Let me show you the state where she is, and you'll get a sense of what is going on in her backyard. And this, the picture you'll see is startlingly different. And I'm sure she is concerned that all this talk about hospitals, we will end up here, right? And if you look at the numbers here, 64.3% C-section rates in a district, 57.96. There's another district, Karimnagar, which is the champion, at 82.4%. I mean, I interpret that data as if you happen to deliver your baby in the taxi on your way to the hospital, well, you got a normal delivery. If you didn't, and as soon as you entered the gates of the hospital, they are prepping you for C-section. So in a state like this, where this is the reverse of what we saw with all the red dots in the previous states. The question in some ways for you, Dr. Fernandez, and I'm hoping you will speak to that, is there another path? Do we have to end up here? Or are there other ideas which kind of take the lessons that Dr. Lee and Dr. Nimako have shared, but set us up in a way that we don't end up where Telangana, unfortunately, has ended up, and where Kerala is ending up, and where Jammu and Kashmir is ending up. So many states have gone the other direction. May I invite Dr. Fernandez to share her views?
Unmute here. Thank you, Dr. Moore, for that introduction. But to begin with, I want to thank you for inviting me to participate in this discussion. I was looking at the theme of this year's universal health coverage is to build a world we want, a healthy future for all. As an obstetrician now devoted to promoting professional midwifery, I'm convinced if we don't make pregnancy and childbirth safe for every pregnant woman, we have lost the plot. There is no healthy future for that mother, her baby, the family, and ultimately society. I want to thank my two speakers before me for their brilliant sharing of their reflections. And I couldn't agree more with what Dr. Nimako said about the need for building up skilled care. Yes, India has made great strides in reducing MMR and infant mortality. Our institutional deliveries have increased, but Dr. Lee has also shown us that women are probably safer birthing at home than in the institutes. And we know one of the reasons why this is happening is this lack of skilled care and far too many volumes. We don't have enough staff, lack of evidence-based practices. There's also disrespect and abuse by a tired, overstretched staff. And all this contributes to the traumatic experience of that woman, not forgetting the psychological issues, including depression and fear of childbirth. We're talking about aspiration of health as a fundamental right. Similarly, every pregnant woman has the fundamental right to access safe, high-quality care. And this high-quality care is, as we would expect, to be offered by competent, compassionate staff, who will also respect her dignity and right to privacy. And this is where we have an answer. And all of this can be achieved by bringing in professional midwives to center stage. Because a midwife who's trained to global standards, she's an accountable healthcare professional responsible for 2 lives. So she has to be highly skilled. The Lancet, we know in 2014, identified 56 different outcomes that could be improved by adding professional midwives to the healthcare system. In fact, it claims 30% of the preventable deaths could be avoided just by scaling up the number. Cochrane review further emphasized that when you have women who are under midwifery-led care, their risk of preterm births is less, their risk of C-sections, assisted vaginal births, need for oxytocin, need for analgesia is less. And what is even surprising is that the risk of babies born with low ABCAR is less when these women are under midwifery care. We're talking about low-risk women. And at the end of it, mothers are far happier with their experience. Thank God, in India, December 2018, the government was committed to establishing midwifery-led care across its public hospitals. And it's going about this very seriously by trying to develop midwives, or they call them nurse practitioners in midwifery. Now we know that a midwifery-led unit led by midwives trained to global standards, and I emphasize on that, in high volume secondary centers will certainly make a difference. because those women who are risk-free, healthy, and they form quite a large percent of the population, can be taken care of by the midwives. And this leaves, the obstetricians to focus on the high-risk mothers and offer the care that she needs. Normal births will increase, interventions will decrease, overall costs will reduce, and hospital stay for the low-risk women will certainly decrease. She's an expert of normality, we know that, midwives, and so she's recognized to recognize complications early, respond immediately, and call for help wherever needed. And this is the model that India has adopted. And if it actually does spread across our public hospitals, we're talking about this incredible partnership between a highly skilled midwife and an obstetrician working with mutual respect and trust, offering collaborative care. That, I believe, is the way forward, because a recent assessment found that our PHCs and CHCs, and Dr. Nimaku has also alluded to that, at primary birth, and these are our primary birthing centers, but they are so critically deficient. They are understaffed and lack the requisite infrastructure. Trying to birth women in these centers is only going to increase morbidity and mortality too. So what is the way forward? For me, it's very clear. There's enough evidence globally. Midwifery-led units offer that middle path by reducing the likelihood of potentially harmful interventions, access to higher obstetric. Lancet series of 2018 says that midwives are equally good to handle not just low-risk women, but in a tertiary center, they can also be of great help working with doctors to handle high-risk women. So there are subspecialties in midwives, but we won't go there. We know that the midwifery philosophy looks at pregnancy and birth as a natural event. So midwives will promote normal births and a positive childbirth experience. The heart of midwifery is woman-centered care. Thus, midwifery-led units will promote respectful maternity care, which we know is a quality indicator. So if we have a clinically competent, well-trained midwife posted in a remote center in our country, she would risk categorize women. That's her primary responsibility. She will risk categorize and focus on the low-risk women and refer those women whom she knows needs care in a higher center. Therefore, she will certainly decrease overcrowding, unnecessary overcrowding in our secondary and tertiary hospitals. But if we are posting this highly skilled midwife in a remote area, then we must ensure that she's got the basic prerequisites in terms of infrastructure and a robust transfer system, particularly ambulances, not ambulances that fail. So in short, a midwife or midwifery care brought into mainstream, integrated, forming the backbone of our maternal services. And when midwives work in collaboration with mutual respect and trust with doctors and other specialists, keeping the woman and her baby at the center, magic happens. So I'm convinced midwifery is a low-cost, high-quality answer to India. And I think it would answer all the other problems that were shown by Dr. Lee and Dr. Nimaku. Thank you.
Well, thank you, Dr. Fernandez. I'm wondering, listening to you, whether in some ways we've been handed an opportunity rather than a threat, because while maybe the state in which your hospital is located, I don't know what can be done. People seem to have established an equilibrium, like it has happened in Brazil, of, the routine birth. I saw a paper by the head of obstetrics, I think in Mehboob in District Government Hospital, in which, in her mind, the presumption was the right delivery rate, normal delivery rate is 50%. And she was very pleased that she had almost gotten there with 48% normal deliveries. It was a published paper. So, My sense is that the state has developed a certain expectation, but maybe a state like Bihar, a state like UP, which is still early in its journey, struggling to find answers. Are we thinking that maybe there's an opportunity here that we can build something right?
Mm-hmm. I'm absolutely convinced, Dr. Moore, when we have well-trained professional midwives going into these areas, your care improves. First and foremost, the woman is getting highly skilled, competent care. And if the midwife can risk categorize, she's automatically sending the ones who need more specialized care and perhaps a C-section as an intervention that is required, referring that woman on time. So the doctors are not wasting their time looking after low-risk women who don't need their attention. And then with this kind of integration, your C-section rate for the right reasons will be done.
Right.
So you won't have too little, too late, as spoken with these 4 states, because it's low cost, high quality option. I mean, when you bring in midwives, you see the results. Your stay of the woman in the hospital is reduced. And midwifery, they prepare women. It's a relationship built on trust. The monitoring of the woman during labor is high quality. So the outcomes are better. And I believe this will make a huge difference. So if we can fill our public hospitals with a strong backbone of professional midwives, our entire obstetric scene landscape will change.
Well, thank you, Dr. Fernandez, for that perspective. If I may turn a little bit to Dr. Lee back, and I know, Dr. Lee, in your work, you've also studied your own home country's health system. This issue, so there are 2 issues here that I think have come up. One, I think there is general agreement that we need high volume, high quality centers where women are birthed. I know also that the issue of proximity, in some cases, it's not a problem of proximity. In some cases, it is. Many countries have established hostels or short stay facilities for women in the 7th or the 8th month so that they can actually be close to a facility. I know Turkey does that quite a bit. Uganda, Dr. Nimako, I've heard, has a similar system. So these are issues that can be dealt with. But in the South Korean context, I don't know if, what the data is. I know Japan has 18% C-section rates. How has that been achieved? I mean, we are struggling here to, in fact, there is data that has come out of the Obstetrics Association which shows that women are dying now in Indian facilities in the southern states of post-operative sepsis. First, you gave her a C-section that she didn't need, and then you could look after her, post-operative, and she died because of sepsis. There are states like, Dr. Fernandez's state, which has a C-section rate average of 60-65%, yet has a maternal mortality rate that is pretty high. And there's no way to explain that issue. I was keen if, Dr. Lee, you could share with us some experience from South Korea, which has only in the recent 20-30 years evolved its health system. I know you're well ahead of us and it's a highly developed, rich country, but anything that we can learn from that?
The Korean context is a little bit different from India. The C-section rate in Korea is really high. The national average is more than, as I know, 40%, like 43% is the national average. But the maternal mortality, is not related to C-section rate because the process care, like the provider's capacity and also the infrastructure is quite good in Korea. But the reason for high rate of C-section is the intrinsic nature of provider payment system in Korea. We are adopting fee for service. So the government rigorously control the service fee for just a normal delivery. So provider are inducing cesarean section to pregnant mothers, and also pregnant mothers prefer the C-section rate due to some fear of normal delivery, and also the benefit of C-section that they can set the date of delivery. So it's a little bit different from Indian context. Yeah.
Thank you, Dr. Lee. Dr. Nemako, to ask you this question, this idea of midwifery, I don't know if that came up in your discussions in Africa, because potentially as developing countries, we are all traveling a journey. Do we end up with 90% C-section rates? There is actually a district in India that I think has gotten almost there. Or do we remain with the Japanese 18%? I don't know if you have any perspectives to share there.
Thank you, Dr. Moore, and thank you to Dr. Fernandez for that presentation. And I couldn't agree more. And this is the concept of high quality midwifery care is central to the concept of service delivery design. And unfortunately, I didn't have time to talk about that, but that is one the risk of over-medicalization of birth is something that we speak about in our paper and in the concept of service design, and recommend that midwife-led care should be at the center of this redesign. So that if you are shifting deliveries to hospitals, you still have midwives, well-trained midwives, like Dr. Fernandez said, who are managing those beds. And obstetricians and physicians and doctors are only managing complicated cases, which is what they should be doing, and not managing normal deliveries and low-risk mothers. So I couldn't agree more. Midwives are so critical to the success of this model of care, and in general to improve the patient's experience of care during delivery, and to improve outcomes for mothers and newborns. So, yes,
Nemako, one more question. What about the issue of proximity? I know in your paper for Kenya, you found that it was not as big a problem as one might imagine. Even in India, the reality is our road density per square kilometer is second only to France. What people don't fully know is that one of the prime ministers that we had launched a rural roads program, 20 years ago, Prime Minister Vajpayee. Its result is that only France has a better road density. We are actually well ahead of the US, well ahead of China. China has built lovely highways that not many people use, but the rural roads are not as strong. So in a way, for us also, there is a challenge. But whenever we talk about hospital care, people talk about proximity. I know in Ethiopia, for example, one of the initiatives has been that even trachoma surgery has been permitted in primary care settings because of the lack of availability of surgeons and potentially the proximity question. Is that a question that you have a sense how one might deal with? Because, in a country like ours, we will face that question.
Yes, thank you, Dr. Moore. That is a very valid question, and one that we get a lot. And there are many ways to see this challenge. So the first is sometimes in some places where you think that access is so poor, you realize in the end after doing your analysis that it's not so bad. And in the lead up to our paper on service delivery design, some of our colleagues at the Harvard School of Public Health did some analysis with 5 countries, if I remember correctly, included Kenya, Haiti, Malawi, and a few others. And what we see is that in reality, about more than 80% of the population is already living within an hour's travel of the hospital. Now, that's not to say that you blindly implement service delivery design without consideration for the geographic context, because there's that 20% that is really critical, and that may mean the difference between improvement or a decline in your mortality numbers. So while this concept can be easily applied to that 70 to 80%, we need to contextualize it for that 20%. And what we recommend is there should always be the vision. The vision is what's most important. The vision that we have the evidence base that the best chance of survival is where mothers and newborns have rapid access to life-saving care. So while it may not be immediately possible to situate a hospital within reach of every single pocket of the population, the direction of travel is that we are moving to a situation where we give mothers and newborns the best chance of survival by ensuring that when they deliver, they are close to these facilities. So in some places, you could depend on well-managed and well-equipped and maybe high volume, because you need to retain skills, and health centers or primary care facilities that are in close proximity to these hospitals. And in that case, like Dr. Fernandez said, you should have transportation that is reliable and health workers who can do the work. And this includes very skilled midwives. So we should always be looking at reducing the time between identification of the complication and the management of the complication. And that should be the direction of travel. As we evolve, as our resource envelope helps becomes, as we be able to match our resource envelope to the need, because we have a vision in mind, we move towards that vision. Today may work for some places, but we need to develop the contextualized strategies and then move towards a vision of proximity to definitive care.
Thank you, Dr. Mako. I see Dr. Fernandez has her hand up. Dr. Fernandez, if I may also leave a question with you that has come from the audience so that you can respond to that as well. What the question, often when people talk about high C-section rates, and I know we are focused on low C-section rates and low secondary care availability, people say, well, the mothers are demanding. My understanding of the data is that only a small proportion of mothers really demand it, and also obstetrician is in a position of power. She can always say, I'm sorry, I know you might want it, but that's not medically advised and I'm not going to do it. So I don't know what you think about that. You deal with mothers daily, so you have a sense of what's really going on. But, and of course, you had a comment that you were going to make as well. So over to you, Dr. Fernandez.
Yeah, thank you, Dr. Moore. I just wanted to add to what Dr. Nimako said. You stressed the question. Maternal request for C-section when there's no medical indication is a very small percentage of women. If you take we started our audit of 2, and the request by mothers was only 2%. Today, it's hovering around 12%. So it's been slowly increasing. Very reason for a rise in C-section rate. Yeah. Coming back to what Dr. Nimako was saying, this is why India has adopted the model of introducing midwifery-led units within high-volume centers. So your transportation is minimized. But if you do have a remote center where people can birth, then you have a very competent midwife who can risk categorize and support her with a good referral system. That would be for the real remote areas. And that's what I wanted to tell Dr. Nimako. Yes.
Yeah, no, I think it's a very important perspective, Dr. Fernandez. Of course, you are the expert, but my impression is that not always possible to fully risk categorize. Intrapartum, as the delivery is progressing, you might discover that the situation is not quite as, straightforward as you might have imagined. And some 30-35% of women do experience, they were low risk to begin with, even on an ultrasound. But without an ultrasound, I'm told it's hard to risk categorize, but even with an ultrasound, and then you need to refer. And that can become a little bit of a challenge. But clearly, there are other means. I mean, Kenya, I know, has an air ambulance service. If we can reduce the number of women that need referral, then potentially an AMREF, type service could be helpful. But as Dr. Nimako pointed out, that's the vision. We need to get there, and we need to get there slowly, but we need to be clear what the vision is. If you simply don't have any hospitals, well, that's not a situation to begin with. You want to make sure that at least you have competent facilities, and then gradually find a way that we are able to spread the facilities out as needed, with good midwifery care and emergency care as needed. I want to switch back to you, Dr. Lee. One other question that has come from the audience, which is, I think, sparked by your comment about South Korea, is what would you say would be provider payment reforms that as we embark on this task? You said that fee-for-service is partly what is driving the South Korean C-section rates. But in India, as was pointed out at the beginning, since we are at the start of the start, as it were, while we have many problems today, we could design better as we go forward. Any advice that you would have for us based on your experience of payment provider payment models?
Yeah, I would recommend as I mentioned earlier, the rooted problem in Korean payment system is fee-for-service. So the government control the service fee for service that national health insurance is covers, but they don't care. The provider can charge the uncovered service as much as they want. So government wants to care about only the cost incurred from the covered service, because that is directly related to health insurance budget. But the government doesn't care about the cost of uncovered service. So that's why the provider inducing the cesarean section, which is not covered by health insurance. So government made a huge effort to change the payment system from fee-for-service to like bundled payment system, such as DRG, diagnosed related group, or the budget, the total budget. But due to the pet dependence, it's not easy. The provider group have a very big resistance to the change of provider payment system. So I would recommend to start with the national health insurance or any kind of government subsidy system with some bundled payment system. So once the payment provider payment system is fixed with specific type of payment system, it's not easy to change in the middle of the process. So also fee-for-service is very is the system that it's very hard to control the cost. So
yeah. No, thank you, Dr. Lee. That's an important point you're making. In fact, some of the research that I'm engaged in is showing that one of the big errors that the US made was when they announced Medicare, Medicaid in 65 under Lyndon Johnson. They agreed to a fee-for-service system to pay for Medicare and Medicaid. And 50 years later, 40 years later, we find this has led to enormous increases in costs. And because Medicare, Medicaid is so important, it has anchored the behavior of the rest of the health system. And now I think what you're saying is Obamacare is trying to reverse this trend, but it's so hard because people have gotten used to a certain way of doing things. Physician compensations are crossing millions of dollars. It's now hard to go back to a situation where everybody's paid a modest amount, and really there is a different structure. Dr. Fernandez, turning back to you, there was a question from the audience that you might be best placed to respond to. What about the hierarchy in a hospital? There is a sense that doctors, then others, then others, then others. Is that an impediment that you see in evolution of this midwifery cadre? And more generally, what do you see as the blockages that when you advocate for this, what do you see as the problem that people come back to you with?
Thank you, Dr. Moore. When we first introduced midwifery in our own hospital, which is a totally private hospital, I was afraid that women may not accept midwives. But we introduced them during the antenatal period, and slowly the trust grew. And today we have antenatal clinics being run independently by our midwives, and there's a 2-week waiting period for a check for an appointment because we don't have enough midwives for the volumes we serve. Now let's take this into a public setting. It's incredible in Telangana. The women have just embraced the midwives. And the midwives in Telangana have a different uniform. It's a trouser and a very colorful shirt. So they are identified very easily. And women are seeking care of midwives. The problem is not with women. The biggest obstacle I see, and I feel very embarrassed to even admit it, is my own fraternity. We obstetricians, we who do not understand profession of working with them will be filled with a lot of apprehension, fear. And also, if I'm being paid for that service, as Dr. Lee was talking about, then how do I earn my money? So in Fernandez, we're all salaried professionals. We are not paid, fee for service. So introducing midwives was not a problem. Initially, my consultant colleagues were worried, but after that, today they say, my God, how did we ever manage without midwives? So for me, that's the biggest stumbling block. Once women know what they're getting, the demand will only increase. Yeah.
Dr. Fernandez, I think you're making a valuable point. And the one thing that I really like about what you're saying is somehow it makes the public sector well positioned to do this, because public sector even today is salaried. While the payment to the system might be on some budget basis, which is not perhaps the right one, but the individual obstetrician, which is why it boggles the mind a little bit, why these rates are so high in a government hospital. But be that as it may, if we offer new alternatives, it seems to me what you're saying is that public sector is well positioned actually to take on this task with high standards, with high professional commitment to do this, even in remote areas. My understanding from talking to Dr. P.V. Ramesh of the integrated Andhra Pradesh was that building high quality secondary care was something that the state did in a systematic manner, perhaps not with midwives. But what you're saying is very encouraging, that as you introduce midwives, in a way, maternal demand might swing the balance in favor of midwives and away from surgical procedures.
Yeah. In out of the 16 facilities in Telangana where the midwives are posted, the normal births have been increasing and the C-sections have been coming down. The data is very clear, and that's very encouraging also.
So we are nearing the end of our conversation, and what I thought I might request all of you to add any closing remarks that you have. You've heard a rich discussion from each other. May I start with you, Dr. Lee, to see if you have any final words of advice for us as we think about building our health systems.
Yeah. Again, yeah, we talked about a lot of issues today, and I wanna highlight again that we need to make a real change in health outcome. Like we have to care about not only extending access to the health service, but also quality of the health service. And yeah, that's all I want to say today. And also also the design of governance, such as the purchasing mechanism of health service and provider payment system should be right from the beginning.
I think it's an important point, Dr. Lee, that you're making in terms of, because it is true that perhaps in this conversation, we tended to get caught on are there hospitals, are there midwives or not. What you're cautioning us is that that's important, but only the first step. What they actually do, if they are there, do they take the blood pressure? Do they do the ultrasound? Do they do the things that were required to be done? And you're right, that it's possible. We've built all this beautiful stuff, but people are not doing. And in there, how they are paid, how they are compensated, both at the system level. In the public sector, fortunately, we have, and largely in the hospital space, I'm hoping that the public sector will step up and provide the services needed. In many countries, public sector has done a good job of providing secondary care. But even there, currently we are following, the 1920s Samashko model, which is budget-based, line item-based processes. Even there, strategic purchasing, outcome-based purchasing, not at the level of the individual obstetrician, but at the system itself could be quite important. So I think, thank you, Dr. Lee. It's very glad to have you here. May I turn to Dr. Nemako for his closing remarks?
Thank you, Dr. Moore, and thank you to my co-panelists and to everyone who joined today. It's been a very engaging conversation, and I'm glad to have been part of this panel. And what I like to remind us all as we close is the first step to any solution is identifying the problem. So it's a great thing that we have realized that the challenge we have and are looking for solutions to them. With that said, looking into the future is important in our world today. A lot of things are short-termist, and we are looking at what you can do today and tomorrow. But we have to develop a vision for what we define as quality, and with that purview, we are able to follow some process to reach that intended target. And I know that the conversation about service delivery design and reorganizing care, it's not an easy one. It will require visionary leadership, and that's what we really need to make a dent in the mortality numbers that we are seeing, and not just mortality, but also morbidity, like Dr. Moore was talking about, C-section rates and the morbidity that's coming from that. So vision is important. We need to consider the outcomes, not just access, and the context that we are working in will determine to a large extent, what's possible today and what we can do in the coming years. So great to have been part of this conversation, and I look forward to India's progress on this road. Thank you.
Thank you, Dr. Nemako. I really liked your third point in one of the slides, that it is possible. We have to keep that in mind. We cannot lose hope. We have to endeavor and move forward. And Dr. Lee's slides, I mean, what is deeply disturbing is that without quality, there's no point in even trying, because we have pushed women into facilities, but really the evidence is showing, and this is new data. This is not data that we're talking about from the 60s or 70s. We're talking about data from last year or 2 years ago, which is the latest data we have. And I must say, it is a deeply disturbing situation, but what you are saying, what Dr. Fernandez is saying, that the solutions are not that far away. We might not be able to train obstetricians at the numbers needed, but we can certainly train midwives. In fact, Dr. Fernandez herself, her foundation runs one of the eminent training programs and syllabi from which can be used by anybody that decides that they want to create a midwifery program. And I'm a great believer that we should not be Malthusian in our thinking. We should look at the possibilities, not a culture of shortages, but a world in which we are exporting midwives to the rest of the world, because we have now solved our problems to it. So thank you, Dr. Nimako, for contributing your perspectives. Dr. Fernandez, over to you. You've heard a rich conversation so far. Any parting thoughts, any suggestions that you have for people that might be listening in from the government, from the private sector, as to what they might do?
Yeah. Thank you, Dr. Moore. While I see the government is very committed, and I see more and more national midwifery training centers training the trainers so that we can scale up more midwives, makers, and the government, is why are you not introducing midwifery in the private sector, where our C-section rates are very high? That is where we need midwifery. And if there could be some form of mandate or policy that, wherever hospitals are offering maternal and newborn services, maternity care, we should have midwives as part of our workforce. And lastly, if FOXI, 35,000 strong membership of OBGYs, if we could support the cause of midwifery and open our minds, our hearts, and our birthing rooms to professional midwives and work with them with respect and trust, women and their babies are going to benefit, and care would improve vastly for all women across the country.
Thank you, Dr. Fernandez. It was wonderful having all of you here for this discussion. I really cannot thank you enough for taking time out. Dr. Lee, I know it's getting late for you, but thank you so much for staying on to participate in discussion. What I'm sensing here is a path that we could potentially think about. I mean, the situation in the 4 states that we mentioned is truly alarming. I mean, I do not want to understate the reality that if a woman needs an emergency care, it's not available because there are no hospitals. It's not that we are only talking about proximity. We just do not have them. And they're not at the level at which they need to be. There are many problems. If you talk to state governments, they will tell you finding the specialists, finding this, that, and the other is a challenge. So I'm not going to trivialize that this is a problem that can't be solved, but there is a need to focus. There is a need to move forward in a careful way. Dr. Lee's evidence, Dr. Nimako's papers show us that this is now showing up in the data. It's not just a matter of my view versus somebody else's view, in which we are arguing passionately about, do we like the color red or do we like the color blue? This is really all about, analysis pointing us in a particular direction. And if I read the report of the Lancet Quality Commission, again, you see that message coming through loud and clear. Now, one might say, what is the solution? Will we end up as a country where Telangana is, where Kerala is? Where are the doctors? Where are the obstetricians? And Dr. Fernandez's work, and I'm deeply inspired by what she does. It hasn't been an easy journey, shows us that there is a pathway available. It's not obvious that the right answers are only in the one extreme or the other extreme. There is a pathway available to us. It's not high cost. It offers a career path for women who are already perhaps trained as auxiliary nurse midwives or as nurses who wish to move up the ladder and do something more going beyond this. we are able to build proximity. We are not, I mean, indeed, India is a large country, but as I said earlier, we do have the roads, we do have the capabilities to move people. And you know, I like Dr. Nimako's guidance to us that, you know, we have to set a vision, we have to set where we need to go. But it seems to me that there is a hopeful path out there that we can all pursue as we think about the future of Indian health systems. So thank you all for joining us. I really want to thank Pooja and Tamra for their guidance and their support all through. You would have seen them in the background, making sure that we are all able to move forward. I want to thank the audience that has stayed with us and participated in this complex conversation. And thank you all, and have a good night, good afternoon to Dr. Nimako for joining. Thank you very much.
Thank you.
Thank you.